Good morning, and I would like to welcome everyone who is present in the chamber and those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would also add that for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and leave into the car park at the front of the building and wait further instructions. I would also request all members to place their phones on silent and to ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item and keep those succinct and concise. As the meeting is being streamed in the usual way, I would like to remind you that your comments will remain accessible online. I'd now like to move into agenda item 1, apologies for absence and replacement members. Emily.
Thank you, Chairman. We've received apologies from Councillor Sarah Parkin, Sandra Harrison and Penny Robbins.
Thank you. I'll now move on to agenda item 2, declarations of members' interest. Do members have any interest to declare at this point? No, thank you. In which case, I'll move on to agenda item 3, the minutes from the 15th of March. You will find these in the agenda pack on pages 3 to 10, and I plan on taking these on block. Do I have a proposer for these, please? Thank you. Councillor Linda Wotton, seconded. Councillor Smith, thank you. All those in favour, please show. That's supported, thank you. In which case, I'd now like to move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda and supplementary announcements were circulated on the 18th of April. I would like to draw the attention of members of the committee to paragraph 1 of my announcements, which relates to the pre-election period and how the NHS is expected to engage with the committee. Are there any questions on the announcements, please? Councillor Smith first.
Thank you, Chairman. And with your indulgence, notwithstanding your earlier, earlier remarks, I would be very grateful if I could make 3 points, Chairman. In the areas you've covered with respect to your announcements. With respect to the Hewitt review, it is to be welcomed that a recommendation to review GP and primary care contracts is within the review. This has been long overdue. However, this is tempered with what has been described as population budgets, as without knowing the specifics of this and how it would implement. My cynicism, shall we say, has concern for how this will impact us in Lincolnshire because we are a rural and sparsely populated population, so I fear we may potentially be shortchanged. Secondly, Chairman, I cannot say I'm surprised by the decision of our NHS colleagues to centralise nuclear medicine at the Lincoln County site. However, it would be remiss of me if I did not put on the record that I believe this to be a mistake not to maintain two sites across such a large county. The county needs to have sufficient health offerings outside of the City of Lincoln, and this plan further undermines the premise of that and will obviously necessitate excessive and extended travel for residents who are not in the centre of Lincoln. Finally, Chairman, with respect to the use of opioids, I am all for reducing their use in the right circumstance, but I think it would be helpful for the committee to have NHS colleagues come before us on this issue, as what I wouldn't want to see this strategy do is make doctors, etc., unwilling to keep those patients on those drugs that need them or prescribe them when appropriate. I have seen firsthand the benefits they can bring to those. I have helped, and also in terms of the use of gabapentin and other such medication. I myself, due to medical issues, I'm very limited in what I can and can't take for pain management, and so I've seen the benefits of those as well, so I would hate for them not to be prescribed due to this new strategy. So I think it would be very helpful, Chairman, if our NHS colleagues could come before us at their earliest convenience and expand on this. Thank you.
Thank you, Councillor Smith. I believe that all of those points are picked up in the work programme anyway moving forwards, and they are listed to be coming in front of us after the election period. Councillor Allen.
Thank you, Chairman. And with your indulgence, it's a comment, not a question. Is it possible for the CQC to carry out inspections on a health service provision that doesn't actually exist, such as dental care?
Thank you, Chairman. I mean, yes, if there is a all NHS dentists are required to register with the CQC, and as a result of that, they will get regulated by the CQC. But I take the point in the question that if there isn't anything to inspect or regulate, that cannot be done. Thank you, Chairman.
Thank you. Councillor Chalmers.
Press the button. So the closure of dental practices in Boston and Skegness is just heartbreaking. I have a young family. It's our Bupa service that has gone. My son yesterday was here in Lincoln for orthodontic treatment. I've calculated over the next 2.5 years that they're predicting the treatment's going to last. It's going to cost me personally £3,250. And we've just made dental care in Lincolnshire a rich man's game, which is absolutely devastating for everybody with a family that's entitled to that treatment and that care. We seriously need to be looking at ways to encourage people to come back to Lincolnshire to practice, because it has so much to offer and we're absolutely failing on every point. It's heartbreaking. The use of opioids, my father was a doctor and he never prescribed opioids. He said it was a very damaging drug. Alternatives are available. I can't talk about your experience, Councillor Smith. So I'm really pleased to hear that. Thank you.
Thank you, Councillor Chalmers. Yeah, I'm sure we're aware that it's a national problem with dentists, and I think a lot going privately now, and contracts is something that I think needs looking at for the NHS realistically. What has been said is obviously this has now moved to the ICB board, so there will be a more local approach, but it's taking time to roll out, and hopefully better recruitment and retention ideas will be put forward with more local control over it. So I take on board those comments. Thank you. Any other comments on the announcements? No, in which case do I have a proposer that we note these, please? Thank you, Councillor Smith, seconded by Councillor Allen. All those in favour, please show. Thank you, that's noted. I'd now like to move on to agenda item 5, the Joint Strategic Needs Assessment for Lincolnshire. This item was circulated as part of the agenda pack on pages 21 to 34, and I'd like to welcome our presenter, Lucy Gavin. So I'll hand over to you for a run through, and we'll take questions at the end, please. Thank you.
Thank you, Chairman. So the Joint Strategic Needs Assessment, Lincolnshire Health and Wellbeing Board has a statutory responsibility to publish a Joint Strategic Needs Assessment, which tells us about the current and kind of projects some of the future health and wellbeing needs of Lincolnshire's population. Following an 18-month review, our new Joint Strategic Needs Assessment was approved for publication by the Health and Wellbeing Board last month. So what is the Joint Strategic Needs Assessment? So it provides, as I say, it provides a picture of our current and future health of the Lincolnshire population. It looks at a range of areas, so things such as health behaviours, health conditions, the needs of particular vulnerable groups within the county, and generally is there to give us a good understanding of the wide factors that impact on health and wellbeing. And our information within the JSNA comes from a range of sources. So things like national data sets, it comes from registrations of births and deaths, some of the information we get from the NHS directly and some of our own local authority council services, as well as information that we've pulled from local consultations and events. So we use a wide range of information to collate our overall picture. And within this new JSNA, we have a range of topics which have got a narrative which has been developed by authors from across Lincolnshire County Council with support and some leadership from district colleagues and from colleagues in the NHS, as well as relevant expert groups where we have them who've been able to help us to shape specific fact sheets. So, for example, we have a fact sheet on autism that has been co-produced with the Autism Board. So we have a range of people that come together to produce the JSNA. And as I said at the start, it's a statutory requirement for local authorities and local health partners under the Health and Care Act. If I could go to the next slide, thanks. So we've redeveloped the JSNA, and it takes a life course approach, and I'll come on to a little bit more about what that means when I get to the next slide, but it effectively looks at childhood, adulthood and older adulthood. And what we've tried to do within this new platform and new version of the JSNA is create something that tells the story for a range of different topics, but that also has data which updates automatically. So we've run previous iterations of the JSNA, and it's tended to be, it's necessarily had to be sort of a static document, a snapshot of a point in time that we would use for 2 to 3 years to influence our practice. With this new JSNA, the data will update in as close to real time as possible once we've got that new data. So what that means is it will be more interactive for anyone that is using the JSNA. They can run reports on specific topics or specific parts of the data, and the data will automatically refresh and update itself. So it's quite a big step change for us in terms of the capability of our JSNA in Lincolnshire. So as I mentioned just a minute ago, the JSNA fact sheets are divided into 3 sections of what we would kind of typically call the life course. So the first section focuses on starting well, everything from kind of the pre-conception period through to 18 or 25 for young people with special educational needs. And there are a range of topics in there. For example, we've got things around breastfeeding, around childhood weight, oral health, and a range of other fact sheets that are important and have been pulled together by colleagues from across Lincolnshire. For Live Well, this focuses on the period sort of from 18 through to 65, so that kind of working age, adulthood. And again, there are a range of topics in there on things that influence our health and well-being, so things like housing and homelessness, things like mental health and well-being, so we're looking at outcomes as well, mental health and well-being, and a range of physical long-term conditions as well, so for example, cardiovascular disease. And then as we move into the ageing well section, it looks at the factors that support people to age well, and includes things, for example, around dementia and falls prevention. So we can see there is a sort of a slight, as we go through the life course, a slight change in focus of what some of the fact sheets talk about. Go to the next slide, please. Okay, so this is just a snapshot of what the website looks like. It's been live for a couple of weeks now, and we can make sure that the link is circulated for any colleagues that would like to go in and have an explore, and I really would encourage you to do that. There's lots of really good information in there, and as I say, it will be updated, so it will change over time as we learn more, so it should hopefully be a really good interactive resource moving forwards. We have on the landing page some information around the population in general, which is what you can see here, and then down the right-hand side, it's got all the different topics that appear in that starting well section. Emily, if I could just get you to click a couple of times, there should be some text that appears down the side. We'll do it all in once. One more. Brilliant, thank you. So this is just a little bit of navigation information. So we do have an infographic video that gives a summary of the JSNA and what it's there for, and how it's shaped in terms of those key features and key life stages for Lincolnshire residents. The links appear down the side. So if we were to be looking, for example, at the ageing well section, those green boxes would be red because that's the colour theme for the ageing well, and the topics would have changed slightly. And what we've also done just in the bottom right-hand corner is we've got some links to other useful resources that sit outside of our Health Intelligence Hub. So for example, here in the Start Well section, we link across, for example, to information that's available on child and maternal health profiles, for example, and that again adapts in the different sections so that it reflects the kind of the part of the life course that the section is focusing on. And then for each section, you can also download some of the key infographics and some of the key points for each life stage. So if you wanted to share that in kind of a more digestible format or as a hard copy, then that's sort of those facilities are built in as well. Within the narrative on the fact sheets, each one's structured in the same way, so hopefully makes it easier for people who are looking for information. They know where to look within the different fact sheets. So here's an example from Healthy Weight, and each chapter includes some background information, some policy context, which picks up on the both the national and the local policy around the given area. It then describes the local picture. So what does the local data tell us about healthy weight in Lincolnshire? We then talk through some of the local response. So what are we currently doing at the moment for the given topic? We've then got a section that talks about community and stakeholder views. So this is drawn from a range of different sources, including consultation work we've done, where we've done kind of research in specific local communities, and we pull all that together to kind of develop that community and stakeholder view. The sixth section is where we've reflected as a team working on each fact sheet and what some of the gaps and unmet needs are at the moment, those areas that we really want to focus on in terms of prioritising what we do next as a system. And then finally, just that commitment to what those next steps are going to be. And they tend to be, a lot of the next steps tend to be focused on sort of the next 12 to 18 months. So again, that's another thing that will iterate over time, and we should see progress as we've hopefully addressed some of those gaps and unmet needs, and our work will evolve based on what we are kind of our ongoing updated understanding of the situation in Lincolnshire. I touched very briefly before on the fact that we'll be able to download reports, and that the reporting is interactive. So if you do have the opportunity to go to the website after this meeting and just kind of have a look around, what you'll see is that there's various data that you can look at within each section, and it's presented in this format, so it's quite visual. We've used maps where it's appropriate. And also done comparisons to the regional average and the England average, again, where we've got that information and where that's helpful so that we can understand how Lincolnshire benchmarks against some other areas. And as I say, we've used routinely updated indicators, so we'll be able to track this over time. There's also some other, so we've got a number of fact sheets that sit in that Live Well, Start Well, Live Well and Age Well section, but there's also a lot of other information in there. So I think one of the areas that's really important is under the Joint Strategic Needs Assessment banner, we've got a section that's about our people, and what that looks at is specific communities of interest that we know we have in Lincolnshire. So within there are about 8 or 10 different population groups that we've identified. So for example, transient populations who might come in for part of the year, particularly in the summer, veterans and military families, people who are refugees or asylum seekers. So we have within that population section both an overview of some of of that population and what it looks like for Lincolnshire, but also link across to specific fact sheets where there is more intelligence around that population and how we support them. And yes, so really, I think what we're trying to do is encourage colleagues and encourage yourselves to get involved. The JSNA will continuously be updated, so I would really encourage you to get online and have a look. If you've got any questions or things that you'd like to contribute or us to consider contribution, then we've got a dedicated email address where we're collating suggestions, and because this isn't a static document, because it will be a continuous process of review, it really gives us that chance to make small and large changes as we need moving forwards. So that's everything from me. Thank you very much.
Thank you, Lucy. We'll start with questions. I've got Councillor Allen first, please.
Thank you, Chairman, and thank you for the presentation, Lucy. Within the health industry, it always amazes me that there is so little representation for the actual customer, you know, the patient, the public, in relation to health provision, and the significant amount of monies, of course, that the public put into the health industry as a whole. So any initiative that looks at it from that perspective, I think, is very, very welcome. The question I've really got, though, is that whilst obviously a lot of work has gone into this assessment, and it is a very targeted one in terms of Lincolnshire, so it is very good in that respect, and it does say, I think, in the covering report that it's available for partners to look at. and presumably make some sort of assessment about what it is that you're pointing out to them and actually reacting to it in a way that deals with some of the issues that you've identified. The difficulty I've got is, what degree of control, because I know that's the wrong word entirely, because you probably have no control whatsoever, there is to actually ensure, or encourage even, rather than ensure, that the people providing the health protection in Lincolnshire actually do take any notice of it whatsoever and react to it in any form of positive way, and at least use it as a mechanism for actually providing some sort of target in terms of how they respond, or even encourage them to respond at all, or respond more positively than perhaps might otherwise be the case. I'm thinking, for instance, as and I think there's a distinction required from the health issues that are caused by people's lifestyles as opposed to the health issues that may be simply there because of age or whatever it is. But I was thinking about somebody that's waiting for a hip operation or a knee operation or whatever it is, whose health and well-being, and I think it's both aspects, is significantly affected because they can't do lots of things, maybe not even work. Because they are on a waiting list, and that waiting list is getting longer and longer, and there's no end in sight in terms of when an operation might become to allow them to get back into either a productive lifestyle or a lifestyle that's a lot more effective than it is at the moment. So I see what you're trying to do, but I don't see how you're going to achieve any of it, if you see what I mean. It's certainly in the pure healthcare provision. I mean, hopefully, maybe you might be able to affect lifestyle choices and so on. But I'm really interested in terms of how the NHS reacts to the report that you provided. Thank you, Chairman.
Yes, thank you, Councillor Allen. So one thing I suppose to start with is that the JSNA has been co-produced with colleagues from the Integrated Care Board and across the NHS. So notwithstanding that doesn't mean it might not be used as much as we would like. But one thing I would say is that we are planning a series of, I suppose this is only the start of the journey. We are planning a number of different engagement events with targeted groups across the NHS and also broader. So if I talk, for example, about mental health, learning disability and autism, we've co-produced the fact sheet together, and we are using it already to guide our action planning for the year ahead. So I think there are lots of examples of where it's being used at a strategic level, and we need to make sure that that then influences what happens kind of tactically and operationally within services. The other area in which we are one of the other areas in which we are kind of promoting this is with colleagues across the community and voluntary sector, because one of the things that we've known for a while is that they're often looking for good reputable sources of support, of intelligence to support with bid writing, with funding applications, and again the JSNA is something that can really support with that, because it's the latest intelligence that we've got for the Lincolnshire population. So there are different ways in which we will use it and keep sharing the JSNA and encouraging it to be used in practice as we move forward.
Thank you, Chairman. I'd just like to come back. I'm quite sure that you're doing your absolute best to actually achieve some real improvement. And I'm very pleased to see they've got all these training events, seminars, whatever you want to call them, set up. But it does seem to me that, one thing that seems to be happening in the NHS is it's doing more and more work, but it's providing less and less productivity in terms of outcomes for actual people that require treatments of various sorts. It does seem as though there's more and more effort going into the sort of thing that you're talking about, rather than treating the actual issues that we've got in the health service in terms of providing real health improvements to bodies.
There is a lot happening at the moment, because we've had the joint strategic... Oh. A person. Yeah. Yeah, absolutely. And there has been, or there is at the moment, there's been a big shift around within the NHS and within the integrated care kind of board with the focus on population health management and the joint strategic needs assessment. And together, that is a lot of work around trying to understand what is currently happening and what people are currently accessing in terms of support and sort of the health outcomes across the population. You're absolutely right, we do need to use that to shape the services, and that is something that is a priority for us, and we work closely with colleagues across the NHS, but it is a work in progress.
Okay, thank you. Councillor Loughagan.
Thank you, Chair. And thank you, Lucy, for your presentation. It's good to have all this information accessible, and it must have taken a great deal of work. I think my question is in some ways similar to Councillor Allen's question, but you say you cover the subject of oral health, and this relates to something that came up in the Chair's announcements. And, you know, what does it say about oral health? And we all know, without looking at the information, that the situation is absolutely dire, and it's our job as councillors to represent the people on the receiving end of this. So how can it be used to facilitate government awareness that this is a total crisis and it's totally unacceptable for people not to be able to access a dentist unless they've got hundreds of pounds in their back pocket, which huge swathes of the population don't. And even those who are reasonably well off still can't afford an expensive treatment with a private dentist. So I'm sorry to bash on at you about this is not your fault, but data like this is really great, but it's only as great as what it can do in terms of drawing attention to things. Thank you.
Yes, it's a really good point and very topical with the challenges that we face around oral health in the county. What the Joint Strategic Needs Assessment tries to do in the space of oral health is really set out the overall picture in terms of oral health need, but also inequalities in access and outcomes. A lot of the data that we have relates to children and young people, so our focus in the oral health section is, a lot of the work is around children and young people. What we're using it for, and I appreciate this is, it's perhaps not as tangible at the moment as we would all like it to be, but it has directly influenced the dental strategy that the Integrated Care Board is in the stages of finalising, which includes it's got 4 pillars in there. One of them is around prevention, and so it shapes our activity around prevention across the county, targeted to those areas that have got the greatest need, but it's also influencing around dental access and dental workforce, and how we can, and shaping what we need in Lincolnshire, the dental workforce, to look like in the future, so that, and as quickly as possible in the future, so that it meets the needs of the population now and as we move forward. So that's an example, I suppose, of where the JSNA has directly influenced that strategy. We now have action groups that sit under those 4 themes within the strategy, who are working with working directly with the commissioning team, who work directly with organisations like Health Education England, who support with who lead on the training of dentists and the wider dental workforce. So it has, because it's kind of shaped that overall strategy, and then that's feeding down into specific tangible actions on the ground. It is shaping the conversation, but the changes will take time to embed.
Thank you. Do you think by focusing on oral health of children and young adults, it's much easier to provide a service for a relatively small amount of the population and to solve that than it is for everybody? And it's everybody who needs an NHS dentist. It isn't just children and young people. So I'm sorry, like again, I know this is not your fault, but if that might be an easier fix if you just concentrate on that age group. I'm saying it needs a much bigger fix across the county. Thank you.
And the focus, the large amount of the focus is on children and young people, because we've got some really significant inequalities in Lincolnshire, but also because that's where we have most of the data. So we can develop a better understanding of what's happening for children and young people, and the JSNA is necessarily built on intelligence of a whole range of kind of sources, but a lot of it is based on data that we can collect. And so we have something called the National Epidemiology Survey, which measures, which goes into schools and measures kind of levels of oral health and dental decay in children at different age points. So last year they were looking at 5-year-olds, and this year they're looking at children who are in year 6. So that's one of our best sources of intelligence. So it gives us, it's kind of the best local intelligence we've got. But you're absolutely right, because oral hygiene is really important. That it's a family activity as well. Kind of kids learn from and with their parents. And so if we've got adults who aren't able to access a dentist and who struggle with their own oral hygiene, it's much more difficult for them to pass on, share, and help their children to understand the importance of good oral hygiene and develop those habits. So we do need to focus across the life course. And when we can't speak on behalf of commissioners, but looking at the services and the gaps that we've got across Lincolnshire, it is across all ages, and including older adults as well. We do quite a bit of work with some of our care homes, around needs and care homes, for example, and again, that's another area where we struggle. So.
Thank you. I've got Councillor Smith next.
Thank you, Chairman. In my excuse me, I do apologise for the throat. In my view, I think we've missed a trick in the approach to the JSNA. As I have discussed with Simon previously, excuse me, through my role in the VAPC, one of my colleagues there sits on the board that dealt with Rutland's JSNA, and the approach they undertook was a full comprehensive health needs assessment for all vulnerable groups and specific groups such as the armed forces community, but also travellers and other relevant groups who are either protected by by legislation or have very specific needs. I've read through 2 committee reports on their JSNA, and it's very detailed, and will commend it to colleagues, and I have a copy should anybody wish for me to send it to them as best practice, especially with respect to the armed forces community, but also across the piece. And I think it's a shame that we didn't follow suit in Lincolnshire with a similar approach. Simon and I have had discussions, and he has explained the reasons in this instance as to why we didn't, but I still think it was a mistake. And I think we would have had an additional benefit, as it could have been fed into the JHWS by virtue of our ICS being coterminous with Lincolnshire and local government boundaries. And in my view, Chairman, it's a real missed opportunity that we didn't do that. But I understand the reasons as to why we didn't, but I still think it's a missed opportunity.
Yeah, thank you, Councillor Smith, and I'm conscious that I was part of those conversations with Simon as well. One of the things that I can reassure is that we've had a look at the Rutland JSNA, and the vast majority of the data, the sources of data that are used within that JSNA, within that approach, are included within our JSNA as well. So we do have, we've used similar data sources to understand the situation. So we do have that intelligence. It's just when we're looking at how we present the JSNA, there's lots of different ways that we can do it. So thanks.
Thank you. Councillor Chalmers.
Thank you. I think my points have been covered, so thank you.
Thank you. Councillor White.
I would like to ask how this is going to operate in practice, because I think the local medical centres are not fit for purpose to fulfil the remit of this strategy. For example, they don't have dietitians, they don't have immediate advice for how to improve your lifestyle. The only people who seem to be able to tell people they need to lose weight, or consultants before operations. I mean, several years ago, we were asked to get involved in the formation of a new medical practice at Caister, and we thought, well, ideally what you need is a complex where you get medical advice, where there's exercise facilities, and where you get dietary advice. To fulfill your remit, you need something like that, because what's happening at present is you get referred to outside bodies and put on waiting lists. For example, 1U is one example, and I know I have a neighbour who was told to lose weight for an operation, wasn't able to do it on her own without support, developed diabetes, and recently has spent several weeks in hospital. And this is what happens to lots of people, because you need support to improve your lifestyle. You need immediate advice, I think.
So the JSNA is not a strategy in its own right. It's data that will support the development of a whole range of strategies and action plans across Lincolnshire. So I think it's vitally important that we can use the data to influence those strategies. But then thinking about kind of where that action should sit in terms of who is best placed within the system to support with things around behaviour change, for example. Sometimes it is within a medical practice, but often it's not. Often we're best situating that support within communities, within organisations that are well connected within our communities. And we have a range of services that on offer, many of which to support with lifestyle changes, many of which don't run any waiting list. So people should be able to access that support really quite quickly. And we do work really closely with colleagues in primary care, for example, in primary care networks, as well as secondary care, to try and make those pathways as smooth and as seamless as possible. And acknowledging that it won't work for everyone, and we need to learn from where it doesn't work and adapt where we can.
Okay, thank you. Councillor Cleaver.
Thank you, Mr. Chairman. I'm just looking at the hub now on the web. It is very impressive. And I think one of the things that actually, in all fairness, we should acknowledge the fact that the NHS is very, very good at collecting data. And very, very good at, and you're very good at presenting it clearly. It's a very rich resource. And yes, it is one thing that we're grateful to have, because it's the basic building block of knowing how we build a strategy. So, you know, all praise to you and your colleagues for that. And it's great that we have such a good public health service in the county. And I think that needs to be said. I think my concern, knowing how overburdened our primary healthcare system is at the moment, is how this information feeds through to a strategic view locally and a strategic outlook by our primary care providers, both PCNs and individual GP practices, who clearly are actually having to behave tactically all the time rather than strategically, because they're overburdened. And I think that's the issue. I've got no criticism of this at all. It's the question now of actually moving forward from it and making sure that it is used in a strategic way, with all this great rich resource of data that we have. Thank you.
Thank you, Councillor Cleaver. Yeah, and one of the, so on the same Lincolnshire Health Intelligence Hub, you might not have got to it yet, but there are later on where it talks about profiles. We have got profiles for each of our primary care networks as well. And what is going to be really important is that we can use those primary care network profiles together with the Joint Strategic Needs Assessment, because we don't have, one of the challenges we have within the data is that it's often collected at different levels or in different places, and that means you can't necessarily overlay everything exactly how you might want to. Some of the data is collected at a practice level, and that obviously gives us a much smaller geography than some of the data is collected at a county level. So it's really important that we, and this has got to be an ongoing conversation about how we use the primary care network profiles with the Joint Strategic Needs Assessment, and have that ongoing dialogue and work together to develop the strategies to understand what's what the key priorities are in different places, because they will be, they are different because of the makeup of the local population, historic kind of industry work, kind of how rural places are. Those challenges do vary quite considerably from place to place.
Thank you. I haven't got any other speakers, so I've got a couple of questions myself. The first is, the Lincolnshire Health Intelligent Hub only went live a week ago, but has there been any feedback to the data on the website in terms of ease of use of presentation?
So I'm not aware of any specific feedback since it went live, but we did do some kind of soft testing before it went live to check the kind of the navigation and etc. was working well. But that's certainly something I can come back on. One of the things that we are really keen to ensure is that it's kind of accessible to a range of different potential users. So something we'll be watching closely.
Thank you. Just taking the topic of cancer, including its diagnosis and treatment, to what extent could the JSNA assist this committee in its scrutiny of this topic?
So the chapter on cancer talks, I suppose, as all of them do, about the local picture. So I think one of the things that the JSNA is good for is helping to understand the bigger picture around cancer. What are the key what are the cancers that are more common in Lincolnshire? What are the cancers that perhaps have the lowest survival rate, so that we can develop that rounded understanding of some of the challenges around cancer, because it is a really complex area of work. It's cancer, sort of an umbrella term for over 100 different types of cancer. And so I suppose the JSNA is there both to help with understanding of which cancers cause the most health harm in Lincolnshire, and also to understand what some of our priorities are and how we can support with prevention as well as treatment and recovery from cancer. So,
my final question is, as the JSNA is now a live document, how easy will it be to keep it up to date?
So we have direct control over the website, what goes on it. And we, as I say, we've got our dedicated email address where people can share in comments, and we'll be able to kind of take things back through conversation as we're sharing as well, to make sure that we can adapt it as we need to moving forwards. We, within the public health intelligence team, we've done a lot of the building of it ourselves, kind of once we had a framework. So we are confident that it will be that we'll be able to keep it up to date, really, and respond to feedback from across the system.
Okay, thank you. In which case, I would like to propose that we note the publication of the Lincolnshire Joint Strategic Needs Assessment, and to look forward to using to support future scrutiny activity. Do I have a seconder for my proposal? Thank you, Councillor. Okay, all those in favour, please show. Thank you, that's supported. And thank you, Lucy, for the presentation. We'll now move on to agenda item 6, the Joint Engagement Approach, Joint Health and Wellbeing Strategy and Integrated Care Strategy. This item was circulated as part of the agenda pack on page 35 to 40, and I'd like to welcome our presenter, Alison Christie, Programme Manager for Lincolnshire County Council. I'll hand over to you to go for it. Thank you.
Thank you very much. I think this sort of follows on nicely from Lucy's report about the Joint Strategic Needs Assessment, because one of the other statutory responsibilities of the Lincolnshire Health and Wellbeing Board is to produce a joint health and wellbeing strategy based on the evidence of need that's identified in the JSNA. So, as the Chairman said, I'm bringing a report today talking through the engagement process that we've agreed with the Health and Wellbeing Board and the Integrated Care Partnership to look at refreshing the joint health and wellbeing strategy and the next iteration of the integrated care strategy. So just as a bit of background, I say that the joint health and wellbeing strategy is a statutory responsibility of the Health and Wellbeing Board, and our last strategy was produced in 2018. Obviously, there's been the pandemic since then, and we've had the introduction of the integrated care systems, which meant that the landscape and within which we're operating now has slightly changed. So we need to refresh that strategy to reflect the new JSNA and the needs in that, and then to review it alongside the update of the integrated care strategy, which I believe you had an update on in December of last year, which was the interim strategy, and we're looking to reproduce both strategies by December of this year. So we've agreed a joint engagement approach because of the reason of trying to align the two strategies. So the joint health and wellbeing strategy is the what. So what are our priorities in Lincolnshire? And the integrated care strategy is going to be the how. So how is the system going to deliver them? So the objectives of our engagement, which is set out in the report, is to really reaffirm that the current 7 priorities in the joint health and wellbeing strategy are still valid, to look at the evidence to identify whether there are any gaps and whether there are anything else that needs to be put forward as a priority, and then to think collectively about how partners and across the health and care system work together to deliver not only those priorities but the ambition in the integrated care strategy. At this point in time, we've been advised that because we're not proposing any changes, that this isn't engagement with public at this point. So the work we're doing at the moment is very much with our partners and stakeholders, and we're holding initially a workshop next week with member representation from the Health and Wellbeing Board to look at prioritising the JSNA. So on Appendix A, there's a matrix that shows outlines the approach we're going to take. So it's what our intelligence team have done, have mapped all the fact sheets that Lucy spoke about in the JSNA using that grid. So they've looked at the data and the evidence. There is some element of subjectivity to that because it's not an exact science when you're trying to assess homelessness against cancer, for instance. So there is an element of subjectiveness in there. But they have mapped all those fact sheets onto there, and then the workshop next week is going to look at whether that finding is right, and have some discussions around what do we think of the sort of evidence that's coming out of that and what we should prioritise. We're then going to do some work with various groups and boards between the end of April through to June. So we're going to be going to a number of boards like the Mental Health, Learning Disability and Autism Board, like the Housing, Health and Care Delivery Board, and with our partners such as District Council and everything, to then discuss the outcome from that workshop and to get some more feedback from stakeholders and partners. At that point, at the June meeting of the Health and Wellbeing Board, a decision will be taken about whether any changes are going to be made to the strategies, and whether at that point we need to then do some public engagement through to September. So we're looking to get all that work completed and the 2 strategies redrafted by December of this year and then signed off by the board. So happy to take any questions.
Thank you. Councillor Allen.
I'm sorry, Chairman, I always seem to put my hand up at the wrong time. Or maybe it's the right time. I am actually the first. To a certain extent, my comments follow on from the ones I was making before, and you probably aren't surprised by that. I do wonder whether there is an understanding within the health industry about the issues facing the health industry, because there seems to be an awful lot of it's wrong to say that, a good proportion of the effort within the health industry seems to be going into doing the sorts of things that you do, which is quite correct. You know, we do need to actually assess, what is happening to the population, how its health and well-being is changing, and how we do react to dealing with that. And another good proportion of the health industry is actually working sort of at the front line to a certain extent, trying to prevent people from dying. And not succeeding that well because excess deaths are going up, and the age-long longevity, if that's the right word of it, is now decreasing to the extent that the government's got a real problem now in terms of increasing pension ages, with people dying earlier than they have been, in the past. And there seems to be a bit of a disconnect there, because I don't, and it was alluded to by Councillor Cleaver. If your attention is being targeted towards the 7 million, procedures that are required to keep people from dying, and presumably your priority, whatever your strategic requirements are, is going to be, which ones can we prevent from dying and which ones is it too late to do so now? And it does seem as though we're into a sort of purely reactive healthcare provision at the moment, which is being driven by these 7 million, 7.5 million, or even 8 million by the time, the doctors go back to work or whatever it is. And whatever that's the case, the work that you're doing to try and find a more targeted approach to how you go about dealing with health and well-being within the population almost seems to be, I was going to say a waste of time. It's not a total waste of time, and disruptive. It's not totally disruptive, but almost irrelevant to the situation that exists within the health service as it stands at the moment. And until the health service gets to grips with its basic purpose, I don't see how it can really pay attention then to how it should be doing the job better, because it's not doing the job at all at the moment.
Well, I think this isn't, neither the Joint Health and Wellbeing Strategy or the Integrated Care Strategy is focused on the delivery of pure NHS services. This is around the partnership element. So what can the county council do? What can the district council do? What can our voluntary sector do? What can all the other sort of partners that exist in Lincolnshire do to support some of the prevention activity that stops people becoming ill in the first place? So how can we use the evidence in the JSNA to support some of the sort of activities around physical activity or healthy weights and things that then stop people becoming ill? So neither of these strategies is the strategy for the local NHS. This is more the partnership element. But I take your point that we are required by law to do these. So yeah, that's why we're having to do this work.
Thank you, Chairman. Well, I appreciate that, but if it's not, if it's unlikely to achieve anything significant, it does strike me that, a lot of the attention that's been put into all these sorts of things, and that you must be working with partners within the NHS in terms of developing these. I'm quite sure you are. Lucy said she was as well. But there does seem to be a significant part of the industry that is doing these sorts of things, and not necessarily supporting, the frontline staff that are trying to actually stop people dying.
Okay, thank you. I've got Councillor Chalmers.
Thank you. I think mine's more of an observation and perhaps a little bit of a concern. And bear with me, in the 1940s, 17 aeroplanes crashed from the sky in one day, killing all the pilots. And as a consequence, there was an investigation led into it. And what they discovered was a cockpit was designed for the average human, but the reality was there was no average human. There was no one of 4,000 people that met the average leg length, the average ear to mouth range, the average shoulder width. And all of this information that is being gathered and put together on pieces of paper on height and weight and social standing and where you live and the weather on that particular day is interesting, but there is no such thing as an average person. And we need to be really mindful that the information that we're gathering is leading us in the right direction. And in the case of those pilots in 1940, it wasn't. And that's when they created the seats that move and you can adjust the height and the weight and all the other bits. I also, there's a bit of me that really agrees with Councillor Allen. What is my son or your grandson's or your granddaughter's dental appointment now is really the gum disease of the future, which then actually leads on to heart attack and stroke. And there's a clear path of what isn't being picked up at bud stage, leading on to serious health issues and costs to the NHS further down the line. And being reactive is not the way forward. It's the bigger holistic approach. But a big part of that, I'm just really mindful that all this data is lovely, but we can overcommit our ideas and our thoughts and our processes to data that isn't always relevant.
Okay, thank you. Councillor Cleaver.
Thank you. Slightly perplexed and a little bit concerned by the statement in section 1.4 about engagement with the public, where it says meaningful public engagement needs to be focused on matters that have not been decided and could therefore still be influenced or changed by public feedback. I thought this was a new strategy that's being created and that nothing's yet been decided. So I welcome some clarification on that. It seems to me that if you do a public engagement, it's free for people to say whatever they like. It seems slightly undemocratic to tell people that things have already been decided and they can have no influence on them. As I say, especially because this is, as far as I understand it, a new strategy being created since the integrated care system came in. This is our first health and wellbeing strategy, so I don't understand why things have already been decided. Certainly nothing's come in front of this committee to be scrutinised.
Just for information, it's certainly not the first, not at all.
Sorry?
It's not the first one that's been created whatsoever. But I'll bring Alison in to explain further. Thanks.
Thank you for the clarification, Chairman. But yes, I think my point still remains valid. So yes, I'd be interested to know about that. The other thing, just one other point then on that. I can't see, and forgive me if I've not been able to spot it, I don't see any mention of patient participation groups amongst the stakeholders who are being consulted, and it seems to me that they are a very important part of a public consultation for such things. So could I please ask that you consider putting them in as well? Thank you.
Okay, just for clarification, we currently have a joint health and wellbeing strategy. It was agreed in 2018, and we're looking to just refresh that. We're not looking to write a totally new strategy, which is why we've been advised by our community engagement team that it's not public engagement at this point. If from the work we do over the next couple of months, we decide that actually we're going to change the priorities that are in it, at that point it would become public engagement. In terms of the list of stakeholders there, they are just an example. Both the guidance for the joint health and wellbeing strategy and the guidance for the integrated care strategy have an extensive list of people we could choose to engage with. So patient participation groups are included as part of that, so they will be part of the option if we go out for public engagement. Yeah.
Thank you for that. I would make the comment that the world's changed a heck of a lot, particularly the healthcare landscape since 2018. So I'm disappointed that we're not refreshing it from scratch. Thank you.
Okay, thank you. I haven't got any further speakers, so I'm going to propose that we support the joint engagement approach and the methodology for identifying priorities from the new Joint Strategic Needs Assessment, which is Appendix A to the report, and that we include an item in the committee's work programme for the 8th of November on the draft Lincolnshire Health and Wellbeing Strategy and the Lincolnshire Integrated Care Plan prior to their approval in December. Do I have a seconder for my proposal? Thank you, Councillor Hay. All in favour, please show. Thank you. That's supported. And thank you, Alison, for your attendance. We'll now move on to agenda item 7, report of the Suicide Prevention and Mental Health Working Group. This item was circulated as part of the agenda pack on page 41 to 60, and I'd like to invite Simon just to present it. Thank you.
Thank you, Chairman. This report brings together the views of the working group, which met over the course of the last year and had contributions from Lucy Gavins and colleagues on the side of the suicide prevention strategy, but also a number of colleagues from LPFT who were able to provide in the working group format a certain amount of detail, and also, I suppose, also in the working group format, some detail and challenge, responding to challenge on some of the issues relating to LPFT, particularly in terms of waiting lists and access to the services provided. So the recommendations, which are essentially they begin on page 53. In two instances, they are asking the committee to add items to its work programme, which of course, as I will probably be saying in the next item, is going to get busy. And if the committee were to agree those, I would be seeking guidance, particularly on the first one about the mental health in GP practices, because on the June agenda, we do have two GP items, and it's whether this particular topic would be kind of rolled into those or dealt with separately. The LPFT item, you will also see that LPFT are listed in our work programme, but I think that might need to be a freestanding item to cover an overview of the developments in the last year. Because one of the things with the additional funding that has come through from the government is that has been targeted at adult mental health services rather than children's services. The third recommendation is to note the support provided to armed forces veterans and their families. And the final one is to, effectively, I suppose, to Lucy Gavin's, which is about the content of the Lincolnshire Suicide Prevention Strategy, which as it is due for renewal during the course of this year, and to include a little bit more support for and information and but generally support for families of individuals who have attempted suicide. I'll leave it there, Chairman, and hopefully other members of the working group will be able to answer questions, and I'll try and answer questions as well. Thank you.
Do we have any questions? Councillor Allen.
Chairman, I need to find the bit in the report that it was to do with the fact that the working group had found that I think is it 2/3 of suicides had already tried to seek some form of mental health. It was a follow-up sentence that said something to the effect that I think 1/3 had either not got it or got the support that they were seeking. And I wasn't sure whether it's 1/3 or 2/3 or 1/3 of the total.
I think it's 1/3 had previous contact with LPFT. So I need to find that myself. Excuse me, but I think that's the.
But was it 1/3 of those 2/3, or was it 1/3?
No. I think it's 1/3 had previous contact, and right. 2/3 had not had that. Page 49, I think. Yeah. 1/3 were in active contact with mental health. That's it. Yeah.
So it's 1/3 of the total, or it's not 1/3 of
the. Sorry.
2/3.
Yeah. Yeah.
Right. So it's half, in effect, of the 2/3.
Yeah, 1/3 were in active contact with mental health services of those who had committed suicide. Yeah.
Right. That was just a point of clarity, Chairman. The question, the point I'd like to make is I fully support all the recommendations that the working group's made, because something obviously needs to be done regarding mental health and its provision and its prevention from a suicide point of view. And it doesn't seem as though a great deal is taking place at the moment, and it looks as though it would appear to be a growing problem as more and more consequences of the way that the pandemic was treated come out, as well as perhaps more and more pressure on the younger generation in relation to education and all the other aspects of growing out of childhood and becoming an adult, because it must be a very difficult thing to actually do nowadays. I'm glad I'm not a child at the moment making that transition. So I fully support the working group and the need to actually try and embed better provision for support. I think it must be very, very difficult at the moment to actually seek any form of support, particularly if it doesn't exist within the family. And a lot of the problems are created by the family to a great extent as well. If you are relying on on GP provision, primary care provision, because even getting access to that is quite difficult, never mind getting suitable treatment other than antidepressants. And if anybody rings 111, I doubt very much that I would believe a successful outcome would come from that, because it almost drives me mad every time I actually try and use it. Thank you.
Yeah, thank you, Councillor. And I think that's exactly why they're looking at the 111 option 2, so that it takes that out of the mix, and it would certainly be more useful, because, as you say, it's a one-size-fits-all at the moment when you ring 111, and it's not always, you know, the most accessible in that manner. So I take that on board. Councillor Smith.
Just to expand on Councillor Allen's point, it's actually there is actually a paper specifically on children's mental health that's going to children's, but it's relevant in this sphere, Chairman, if you'll indulge me slightly, because the stats I found were in relation to adult male and females, and it said the amount of people with a common mental health problem went up by 20% between 1993 and 2014. What on earth has gone on from 1993 to 2014 that it shot up that much? It can't all be an internal thing that people suffer with. There's got to be external factors at play, Chairman. And unless we know what they are, we're sitting on a very large bomb that is going to go bang very shortly. And that is why the group that we had was the working group was very timely. But unless we have a serious sit down and conversation with colleagues on a more formalised basis, we're going to have a problem, because there isn't, as you and I know, Chairman, we know through the working group, there is not the capacity in the system to see everybody that needs to see somebody of a qualified nature who is suffering with mental health now, and it's going up. It's not coming down, Chairman. We're going to have a problem, and there's going to be, you know, the emotional harm for the individual that's dealing with that. God forbid if any of them take their own life, and statistics say some will, tragically. There's the hideous amount of grief that causes for the family, and then there's the financial cost to the country, because we have people that need this support and can't access it, and can't live a more normal life. We really do need to have a serious and frank conversation with colleagues, Chairman. The only other point I would make is, and I freely admit I am not a doctor in any capacity or anything, I still remain unconvinced on the NICE guidelines on the use of antidepressants, Chairman, and always will, through my personal experience and through my conversations with the gentleman who unfortunately couldn't make the subgroup owing to the health conditions health issue he had when we were sitting. They were quite serious. He's now recovered by and large, thankfully, but they were very serious, so he couldn't make the committee, unfortunately. And he was very senior in the Royal Army Medical Corps, as I said, Chairman, in the first Gulf, dealing with mental health for service personnel when they were out in theatre. So I don't believe in, or I'm not overly convinced with the view from the NICE guidelines, but that's a personal view, Chairman. But we really do have a problem, mental health issue, not just for adults, but for children. And it seems that it's going to get worse as future generations come from my generation and down. Unless there is a serious comprehensive strategy, Chairman, we're going to have a problem, and the system won't be able to fix it.
Thank you, Councillor Smith. I think if you say about the increase of that 20% between 94 and so on, I think the way that we began to communicate differently was a large factor between there and then. And I think certainly you can see that bullying changes and it's online more now and so on. And so I think that certainly has had a major adverse effect. Did you want to come in? No, Councillor Chalmers.
Whilst everybody's been talking, I've been Googling what happened in in 1994, and that's when internet statistics started coming into play, and it was actually a way that we started communicating. So my suggestion, my thoughts sitting here was that sadly when we stopped talking to each other on a face-to-face and started moving things into a virtual world, we're ultimately social beings, whether you're a private introvert or a wild extrovert. We still need that group mentality, and it's getting pushed further and further away. And I think that's really heavily dominant and seen in our children and their behaviour and their addiction to the internet and computer games, etc. My speculation would be that all of that is behind here.
Yeah, we totally agree. Councillor Loughagan.
Thank you, Chair. Yeah, I've had a look through this, and I appreciate the work that the working group have done. What appears to be missing to me is the very obvious link between mental health issues and drug dependency and drug use, and the lack of communication between mental health services and drug treatment services, and the reluctance to acknowledge dual diagnosis, and the fact that an awful lot of people who are using illegal substances are to some extent self-medicating. Thank you.
Yeah, I think that's an excellent point that probably didn't actually get picked up upon. I'll bring you in a second, Councillor Smith. I think what has been raised by Simon, though, is that what we want to do taking this forward, because of course this is to go on to the work programme. So I would be of the view that where we have got that GP update, I actually think that needs to be separated out. And I think if we're going to do something with LPFT, I think it could, work quite well that you have a GP item alongside it, or we have someone from the ICB talking about how the strategy will work together in reality to ensure that the broken link between GP services often and the mental health services, is somehow repaired, and so that access is easier and better. Councillor Smith.
Thank you for your indulgence. Just to come back on the point Councillor Loughagan made, and then in an organisation I used to be involved in, I was actually dealing with people who had substance abuse, whether that be alcohol or drugs, and somewhere in Lincolnshire there was one client who was in Doncaster. A lot of mental health services will not touch said person until they are clean and sober for X time, and that's because you actually can't. You cannot get to somebody's mental health issue whilst they are on a substance or alcohol, because it prevents therapy, which is why the two can't often work simultaneously, unfortunately. That presents a problem because it's chicken and egg, but medically, from the gentleman who I alluded to earlier, we had many a conversation on this, excuse me, as good friends, and he confirmed to me, no, that you really can't, because actually you can't get to the root cause of the problem whilst they're on alcohol or whilst they're on drugs. The key then is, what do we as between LPFT, others and ourselves, what do we do to get them off the addiction so they then can have full treatment? But what other support do they need to get to that stage where they can then go down into the detail of the mental health? Because most people who are drug dependent or alcohol dependent, it's not because they think, oh, I want to be. It's usually through trauma, and usually through mental health trauma, whether that be something they've experienced in life, whether that be due to service and not being able to deal with post-traumatic stress disorders, as some ex-forces people suffer with. It's usually through trauma rather than through personal choice. There are some that it was through choice that they took substances, but a lot it's through trauma, or as you say, Councillor Loughagan, it's a form of actual pain management for some people that use them. And it's what do we do to get them to the stage where they can then be seen by a mental health professional to then have that treatment, because you can't do both, unfortunately, Chairman. But the key is, what do you do in the interim? And I think that's the piece that's missing. And I'd certainly agree with you, Chairman, that it needs to be, those issues need to be split out and not lumped together, because they're such important issues that if you lump them together, it does it a disservice, and it also does a disservice to the work that we did, and we had help from a lot of people at LPFT and Simon and Lucy and everybody else, and I think it would do a disservice to that work.
Thank you. Councillor Cleaver.
Just 2 points very quickly. On the recommendation 1, could I suggest, it's only a minor thing, but we include PCNs in that. So it would read on the mental health service in GP practices and the role of PCNs in that, because it's something that is something I like, always want to know something more about, is what PCNs are up to and what their role is. So that would be helpful to have that clarification. And could we also, as a committee, record our thanks to the working group, please? Thank you.
Thank you, Councillor Cleaver. Certainly, I was going to suggest doing so. I think in terms of the PCN, I would actually go further and say actually the ICB board as much as anything. I think it needs that whole approach realistically, that it's joined together. So I'd take that on board within those recommendations. Do we have any further comments? In which case, we'll move the recommendations as suggested to be amended with the PCN and the ICB included, and move all three recommendations. Do I have a seconder for my proposal? Thank you, that's seconded. All those in favour, please show. Thank you, that's supported. And once again, thank you to all members of the working group. A lot of effort went into it and it was very worthwhile, so thank you. We'll now move on to agenda item 8, the work programme. Simon.
Thank you, Chairman. If I could just draw members of the committee's attention to the forward plan of meetings beginning on page 62. The theme for the 17th of May is the word temporary, because there are 3 items which all relate to temporary arrangements. We've got the paediatric services at Pilgrim Hospital, which has been operating on a temporary basis since summer of 2019. The Manthorpe unit, which is up to around the spring of 2020, was a unit operated by LPFT as an inpatient older adults dementia care unit, dementia for complex needs dementia patients. And the committee will be aware from previous few meetings, I think it was it January, or where there was an item on the male psychiatric intensive care unit, which has been temporarily closed for about 5 months now. So those items coming forward on the 17th of May, I am aware that we've got everyone's aware, there are district council elections taking place in the first week of May, and I know that the annual meetings of some of the districts may make it a little bit more difficult for getting their membership confirmed for their new council term. But it is quite a big, I think there are a couple of important items certainly on that agenda. I won't go through, obviously we've added the item in for November on the 2 strategies. I would also draw attention to the number 2 on the 14th of June, which doesn't have the word strategy there, but is the NHS Lincolnshire joint forward plan. And that's the strategy or plan for Lincolnshire's NHS services, which is they were bringing to the committee at that meeting. And I suppose it looks like it's a busy programme in the coming months for various strategies and that sort of document, because we've also got the dental strategy coming. Anyway, sorry, I shouldn't mention. But yes, we've got the dental strategy coming forward in July. I'll stop there, Chairman, and take questions. Thank you.
Thank you, Simon. Councillor Rowie-Wotton.
Thank you very much, Mr. Chairman. Simon mentions the word temporary. Grantham Hospital has been temporarily closed now since August 2016. 7 years. I understand now, from information I received, that the model has been agreed to the future of the hospital, which is the UTC 24/7, and I ask that this be programmed in on a future programme. Thank you, Chairman.
Yeah, it's down. Thank you, Councillor Wootton. Any other questions on the work programme? Councillor Chalmers.
Yeah, well, we've got a dental theme. It was brought up in one of the previous meetings about the lack of fluoride in the water in Boston, whereas we have it in Lincoln, and obviously with the lack of dentists in the Boston-Skegness area. Was there any outcome on that? And can we have it updated on the dental strategy?
I believe, I'll bring Simon in, but I believe has it gone to Adults or Children's Committee to be discussed?
I think I need to check on that. I have a feeling that that well, I'm not sure it's necessarily got listed into the work programme of, it's certainly not in the Adults and Community Wellbeing Scrutiny Committee work programme. I will check with the children and young people, but if it's not in their work programme, it perhaps needs to be picked up on the 19th of July as part of that item, if that's acceptable.
I think it's worthwhile to be picked up by this committee anyway. I know that it goes across and cuts into other committees, but I think it's incredibly important. It's something that affects us all, so I'd like to see it back up on the agenda, please. Councillor Chalmers, you want to come back?
Yeah, it does just seem to bounce around, and I don't know whether we can get the water board, but how do we get that fluoride? That's what we need to know, ultimately. Somebody has to take the hand for it. Thank you.
Well, my understanding is that the Health and Care Act, 2022, had provisions in which transferred the responsibility from district councils to central government. I'm not sure whether those particular provisions have been enacted, because I know there are parts of the Health and Care Act, although on the books, I suppose, for a year or so, have not yet been put in force. But that's something I can track down, because it would be, I believe now, I guess it's Department of Health would be taking the lead on this rather than local authorities. Thank you, Chairman.
Thank you, Simon. I've got Councillor Loughagan.
Thank you, Chair. Given that it's come up, I wonder whether we ought to be taking a look as a Health Scrutiny Committee at the 111 service.
Yep, certainly. We can add it to the work programme. Councillor Cleaver.
Thank you, Mr. Chairman. I'm aware that we have given notice to the ICB that we wish to consider their proposals with regards to the future of the minor injuries unit in Stamford. And I think that would tie in very nicely with Councillor Wotton's concerns about the UTC in Grantham. So I think somewhere along the line, we're going to need to put that in, because I think that's quite imminent, certainly in the next few months, that issue will come up. So I think those two could possibly go together. Thank you.
Yeah, it's on the list. Councillor Smith.
Thank you, Chairman. 2 points, if I may. Going back to Councillor Wotton's point, Ray Wotton's point, this is my concern with the acute mental health units, that it's temporary, in inverted commas, closed, because my fear is when things are temporarily closed in Lincolnshire, they stay closed. And if we lose that, that's a problem, especially with what we've just previously discussed. That is going to be a problem. Whether the NHS want to admit it or not is another matter. On Councillor Chalmers' point around fluoride, one thing I would say is we actually will lose fluoride in part of the county that we currently have it in when Anglian Water do work on the pipe network, because there is no legal duty to have fluoride in the water, and when they do the work, the fluoride will be taken out. So a vast, larger chunk of the county is about to lose its fluoridation as well. So it's about to get worse, not better, but I thought you'd want to know. So certainly, Chairman, I think that needs to be picked up somewhere, and I think that needs to be a conversation with dental members of the dental fraternity, the NHS, Anglian Water, and probably may not get them here, but certainly we need to be having conversations with central government and around actually it should be a legal duty, because it statistically shows that it's actually beneficial, and they should be obligated to put it in there, and certainly put it back in if they take it out to do works. But I think, as you said, Chairman, we need to have a discussion on it.
Yes, certainly, and we'll ensure that it does come back. So, and I think in terms of the mental health, we have been reassured on several occasions that they do want to reopen it, but it is on the list, and we will have them back in front of us shortly. So, thank you. Yeah, Councillor Chalmers.
Can we have an update, please, on what's going on at the A&E at Pilgrim Hospital? Because it's like a scene from a wartime film. I know we're supposed to be having an extension and things are going on. It's horrific.
Yeah, we'll try and pick something up within there. To be fair, I was there myself, and you can't even get a drink if you're waiting. So it's pretty atrocious at the moment in time there. But we'll pick something up along on the work programme anyway. So thank you. Any other comments? No. in which case we're happy to accept the committee's work programme going forwards. Yeah, all in favour, please show. Thank you, that's supported. Okay, in which case that brings the meeting to a close. So thank you all very much for your attendance.